Good evening, C.R.E.A.T.E community. It is again Thursday evening, and I'm so pleased to be here today with all of you. Thank you very much for sparing 1 hour to be with us today. For the people who joining C.R.E.A.T.E for the first time, I'm Bashar Muhammad Musa. I'm the program director and I'm associate professor at College of Medicine, University of Sharjah. And it is an honor for me to lead this initiative. And I will be very happy to continue this series of C.R.E.A.T.E webinars to support all the researchers in different places around the world. It's very important to say that this initiative, C.R.E.A.T.E, is a very successful collaboration between University of Sharjah and Emirates Diabetes and Endocrine Society. Today is our 10th webinar, and we do have a very long list of speakers who will come and discuss with us research and how to conduct research and what are the best practice for conducting research. Just a few instructions as usual to make sure that the webinar is running smoothly. So right now our live streaming and the webinar is right now in the ADES YouTube channel. Also, if you have any questions or any comments or feedback, we do have Q&A box in which you can post all your comments and questions. After the webinar, if you want to have the webinar in your computer, you can, drop us an email and order it, and it's available on demand. It's very important to know that C.R.E.A.T.E series is CME accredited, and to get the credits, the CME credits, you have to make sure that you're attending with us in a very regular basis. Today, it gives me a great pleasure to invite a colleague of mine, Dr. Tamer. He's an amazing and very active researcher, and thank you very much for him for sparing 1 hour to be with us today. He's an associate professor of physiotherapy, PhD, who got his PhD from C.R.E.A.T.E University in 2014, specialized in musculoskeletal rehabilitations and sports injuries. Also, he focused in the spine physiotherapy, pain, biomechanics, TMG dysfunctions, and elderly well-beings. He's publishing a lot, very active in publishing, above 50 publications, and most of it indexed in Scopus. Currently, he's the director of the Center of Excellence for Health Aging. And this is a very attractive research area. Many people right now thinking doing research about aging and how we can improve different aspects for elderly people. Currently, he starts and he's advancing research in molecular physiotherapy, which is a new and a very hot field. The title for today is Why Cross-Sectional Studies Matters and What is the Strengths, Impact and Application of this type of studies. The floor is yours, Dr. Tamer.
Thank you so much, Professor Bashar. I'm really happy for your introduction. I'm really flattered. Thank you so much for your kind words. And I'm also happy to join the C.R.E.A.T.E series and this collaboration. I hope we join again and as a listener, not just as a presenter. So today, a lot of the colleagues that are working in research or interested in research are asking about the proper design, how they should look at specific items or pathologies, what goes specifically with the research question. We all know that when it comes to research, the basic thing is you're finding an answer to a question. Okay, so your first idea is you have something in mind and you need an answer. And based on the different interactions and the different ways you're thinking, the designs differ. So again, do you have an intervention? Yes or no? If you have an intervention, then you're going for an experimental design, and experimental designs are a lot. You can have clinical trials with or without randomization. You can have trials on one group of people or the same subject, which is a crossover design. You can have trials on the community or field training at least. But on the other hand, if you don't have an intervention, then we're having observational studies. So for instance, if I needed to see the effect of drug addiction on young age, it doesn't make sense to bring a group of young aged individuals and give them drugs by my own, it's not ethical. So again, it ends up by observing a group of participants that are already under addiction. So when you're comparing for observation, it's either you're describing having case reports or series or something that we're talking about today, which is a cross-sectional study, but a observational cross-section. Or you can go in the other way if you don't have a comparison in hand, so you're going to analyze something. So again, the direction here is, okay, is that group exposed to something? Is it exposed to an intervention, or is it exposed to something that you of interest in your research? So again, if there's an exposure and an outcome measure, and you're looking at it at this time, like a snapshot, that's an analytical cross-sectional study. And we can associate the factors together why this happened now. If you're looking for outcomes of exposure later or looking into the future, you're going to go for a cohort study. So anyway, this is just a glimpse of an idea of different designs or a crash course in designs just to make up our minds before we start. So when it comes to the conduct of research, as we said, it differs based on what is the expected outcome. And some topics, because of their nature, need to understand the history of the conditions, how they developed, and their prevalence or their presence, but with a scientific basis. So basically, when you're looking at that, you need to observe how much they are present in the meantime. And that would be an observational study. When you're having a population in hand, okay, and you need to look at the disease that is happening or an exposure to an outcome, okay, at the present time, okay, so this is what we're saying. You're taking a snapshot, and here comes the cross-sectional design, okay. If you're looking from the present to the past, then you're looking at something that you have done with a case or a series of cases. You're looking for case control studies, but you're looking, on the other hand, to study something happening for now and within the coming future and observing it. Here comes the cohort study. So based on that, we can divide based on that stream of line, based on the time interval. If it's just a snapshot, you're looking under the microscope right now of how much is this present, how much is it affecting, how much is it spread. You're looking for an observational observational cross-section study. If you're looking for something that is now being investigated and how that relates to its treatment in the past or what was happening, you're talking about a case control studies, cases that have been under control for quite some time, and you're looking at what has happened as a sequence of its treatment during the past period. If you're looking prospectively in the future, then you can have a cohort design. So to be a bit scientific, cross-sectional designs, they help to determine the prevalence of a disease or phenomena or even opinion in a population, okay? And that population, of course, is represented by a study sample, but regardless of any attributes or the condition first developed. So again, I'm just observing what's in that population, regardless of the attributes or the condition first developed. I'm not looking for a cause, okay? And each study participant evaluation is completed at one time point, and that's why we call it a snapshot, because there is no follow-up. I'm not following up the findings with time. I'm not looking at what happens next. No, I'm just looking at the present time. So again, when it comes to cross-sectional designs, the beauty of it, it is something simple that you can observe a target population, and from that target population, you can drive your sample and look to the sample and divide it. The sample can be exposed, or a part of it can be exposed, and another part is unexposed. And then when you get to look at the outcomes, there might be outcomes that are developed due to that exposure, but again, we're not looking for the cause, we're looking for the how much development or how much was that outcome present. Or there might not be an outcome at all. And this goes for both groups, the exposed groups and the unexposed groups. So we're looking for the risk of the outcome in both groups. How prevalent was it? And for that, when we're looking at the cross-sectional designs, the outcome has to be related to both exposed and unexposed groups. So you're looking at the exposed with an outcome, again, at the present time, or the exposed without an outcome at all. And on the other hand, you're looking for the unexposed with an outcome at present versus the unexposed without an outcome. And let's give a live example. If you're looking for the prevalence of lung cancer among non-smokers, okay? So it makes sense they have related smoking as one of the risk factors, highly heavy risk factors for lung cancer. Okay, so again, you can have a target group that is exposed and there might be an outcome. But again, those who are non-smokers, we can say they're not exposed to smoking, but still there's a proportion of these subjects that develop lung cancer, although they're not exposed. So if you're looking to a community, an entire community, looking at the prevalence of lung cancer in that community, you can divide them to groups who are exposed to smoking or not exposed to smoking. Or you can be looking at an environmental factor or a pollution factor in an industrial area. So again, in cross-sectional studies, the frequency of any given condition is naturally evolving in the population under suspected exposure. And that factor is analyzed like a snapshot. We want to see it now. I don't want to follow its follow-up with time, and I don't want to know any causative factor or link. We can associate that presence or the association with the outcome, but without giving a causal value, without saying why it happens. As we said, the cross-sectional designs are made or developed to look at prevalences. Okay, and that prevalence can be at one time point, or over a specific period of time, or even serial surveys. So if I'm talking about one point, it's like a prevalence at a specific incident. It's like, okay, did you have asthma today? If I'm looking at a group of subjects that have asthma, and I'm looking at their prevalence of the asthma, how frequent did it happen today for that group? Okay, but if I'm looking at period prevalence, did you have any asthma any time last month? So I'm looking during a period of time. Again, I'm not following up. I'm taking a snapshot of that period or a snapshot of that specific instant. So again, when it comes to period prevalence and point prevalence, they're similar, except that the time frame is broader when it comes to, again, to the period prevalence. Okay, and it makes it a bit difficult to evaluate or observe the entire population at one time point. And this is why it makes sense sometimes to look at a period rather than an instant time. Because if you're looking at all environmental factors around, they have to be related or they have to show their reflection with time. But again, I'm not saying that we're following what happens during different intervals of time. No, we're looking at the prevalence of that outcome within that period of time. So if we're talking about purposes of cross-sectional studies, the first one is surveying populations to come out with outcomes based on the observations. And based on that, we can estimate prevalences and look at clinical samples. A good thing about cross-sectional designs, it can measure both the exposure and the outcome of interest at the same point. We can look at the prevalence of a group of people being exposed, as we said, to a harmful environmental pollutant. At the same time, you can get an idea about the outcome of what's happening. And at the end, when you look at the cross-sectional study, it gives you an idea about the likelihood of something to happen. How likely would that outcome happen based on that prevalence? And this is what we call the odds ratio. Like when you're saying, what are the odds of this happening? So what are the odds of having lung cancer for those who are smokers for more than 15 years? Or for heavy smokers, for instance? Okay, so the likelihood that shows the association between the exposure and the outcome can be easily estimated from the cross-sectional studies. Another beautiful thing about cross-sectional studies is that it can be your platform for other studies. So if you wanted to do a cohort study to look at something that might happen on a group of subjects in the future based on your sample, you can first survey the exposure and the outcome before going to the cohort study. It gives more sense to your study because you have the actual prevalence of the exposure and the outcome. And then it can be a launching platform for your cohort studies. And the same thing goes for experimental studies. You can still have your experimental design with parallel arms or groups, and you can randomize. But before starting your design, your experimental design itself, you can have a cross-sectional study as part or a phase of your study. Because again, it enriches your study. It gives you an idea about the prevalence of the outcome or the exposure you need to look for. And a lot of designs are now mixed model designs. Okay, you can include the cross-sectional studies as phase one, and then you can continue with your targeted design. Of course, as any study design, the data has to have characteristics that it's to be meaningful for the cross-sectional studies. So the data for cross-sectional design is a type of data that can be collected from multiple subjects. You can take it from individuals, you can reach out for firms, companies, facilities, even you can take it from databases related to governments and countries. Okay, and this again is measured at one time point or a period of times. And when we look at the statistics, we are reflecting that as either statistics or econometrics, because the data is very much high and rich. And in cross-sectional designs, the data are collected, as we said, at the same time by looking at the people who are having similar characteristics. You're not comparing apples to oranges. You're comparing the same sample group that reflects the population you're targeting. But they might differ in one or two key factors like age or income or levels or geographical location. Again, a disease can be prevalent in different ages, in people with different income levels or different locations. It wouldn't make a difference. We want to know how much prevalent is that disease present. But again, all the subjects in that sample are reflecting the population we're targeting. For scientific relevance, again, we said that cross-sectional studies, they provide a snapshot of the frequency of a disease or other health-related characteristic, or even something that just infiltrates a society, like a bad habit, but still at a given time point. So it examines relationships between the exposure and the outcome, between the disease and other variables of interest that already exist in that defined population at that time point or for a short period, as we discussed. So again, it discusses or examines relationships. It gives you an overall idea about the prevalence and the presence, yet giving you an idea about the relationship. But as we said earlier, nothing is related to the cause. This is why when they're looking at the burden of diseases, most of the studies are cross-sectional studies, because they provide and they are practical in providing information and the data required during planning and allocation of health resources. Are all cross-sectional studies the same? Of course not. As we said in the first slide, some studies are based on pure observations, others are a bit analytical, and the same is for cross-sectional studies. Cross-sectional studies are either descriptive or analytical or a combination of both. So when you're talking about descriptive cross-sectional studies, it provides information about single or multiple variables, as we said, in the population. Through that, you can estimate the problem or the prevalence of the exposure. There is always a period for that prevalence because, as we agreed, we're taking a snapshot during a specific time period. You can identify the disease and the suspected risks factors, as well as the population or the specific individuals related with that disease or that risk. For the other type, which is analytical, here you're looking not just for the information of the presence, no, you're looking for the strength of the association between the exposure and the outcome. And based on that, we can predict determinants of that disease. We have the predictors or determinants. And again, it gives you an answer to a question. So basically, you're testing a hypothesis through a cross-sectional study. And it's very much simple that you can combine both because the descriptive cross-sectional study is the platform for any cross-sectional study. You need to look at the population or the sample resembling the population, estimate the problem during a specific period, and know that there is an outcome based on the exposure. Then you can go further to analyze the relationship between both. So for descriptive cross-sectional studies, again, it's usually looking for continuous variables. It gives you numbers. So again, it's giving you the mean, standard deviation, or medians and percentiles if you're talking about normally distributed data. So again, anything can be represented within numbers. Okay? And it can also be represented nominally as rates or proportions. Like we're talking about the genders and the smoking condition, if we're talking about percentages. For analytical, again, the most important is that you get with an association and you say how strong it is. And based on that, you can have predictors or determinants of the health condition or the disease. And there are two methods to look at that. The first one is by dividing into subgroups. Remember in the first or couple of slides when we said you can look at both the exposure and the outcome. So you have those who are exposed and those who are not. So eventually you end up with 4 groups with 4 possibilities. That first group is either exposed and having the disease, or they might be exposed but without any disease. The third, they're not exposed, but yet they have it, like those non-smokers that had the lung cancer, or they're free, they're not exposed and they're clear. The second is based on a bit of statistics. When you get to put them in a table, in a 2x2 table, and then get to analyze the proportion of the presence to the total. So you're either looking at the rate of the proportion of the person with the disease, or you're looking at the rate of the proportion of the person with the exposure. So if we're looking at any rate or ratio of prevalence, again, you're looking at the prevalence of those who are exposed and dividing them by the unexposed. So again, the rate ratio is the rate of proportion of the person with the disease over the proportion with the exposure. You're dividing them to get a percentage. And when we're doing so, you get a number starting from 1 greater or less. And this gives you the strength of the association between the disease and the exposure. So again, this is the table I was looking at. So you can divide your groups into either exposed and non-exposed, and those who actually have the disease or don't have it. And then you have the outcomes. And if you're looking at the prevalence, again, of those exposed, you have the percentage of A, which are the exposed, divided by the sum of both the having the disease and those who didn't have the disease. So the sum of all the exposed personnel. Not just to burden your minds with a lot of math, but again, at the end of the day, you're looking for this. You're looking for the rate ratio. And as we said, the number goes from 1, either more or less. If the rate ratio gives you 1, that means it's a 50-50 chance. So they are equal rates between both groups. Okay. But if it's greater than 1, so there is an increase in the risk of the exposed group. But if the rate is less, it indicates the decreased risk of the exposed group. So again, you are comparing those who are exposed with the disease to those who are exposed with and without. And based on that, if the rate comes to 1, then the prevalence or the association between the exposure and the disease is 1, the 50-50 chance of happening. If the rate is greater than 1, there's a higher risk of the exposed group. If it's less, then it decreases. When we are talking about what are the key impacts and the applications? Okay, so if you look at the ladder for research evidence, you'd find cross-sectional designs number 5. Okay, the highest is randomized controlled trials. They're on the top of the mountain. Okay, but this does not necessarily reflect that cross-sectional designs are weaker. No. The difference is, okay, the strength for a randomized controlled trial comes from the randomization that avoids bias and the controlling of the environment of the exposure. Here you're looking at something that is actually happening without your control. And a lot of diseases, like what happened with the COVID, they needed to look at the prevalence of the COVID at some times. So it was out of hand. So if you look at cross-sectional studies, they're fast and cost-effective. You're only collecting data only once, and you don't need much of resources and time than longitudinal approaches. When it comes to a longitudinal study, you're following up with time what happens. So for instance, if you want to see the effect of a specific medication, the effect of a new medication on insulin resistance. So they have a group of patients taking their medicine, and then they're following up their insulin, their blood sugar levels after a month, after 3 months, after 6 months. So they're following up with time. That would be a longitudinal approach. But again, for a cross-sectional, you're taking a snapshot of the present time. Does this medicine or exposure to this medicine improve blood sugar levels, the prevalence of people with less blood sugar levels in that time period or within that month was less than others not using it. So again, it's fast and cost effectiveness. The other thing, as we said, all prevalence studies are based on cross-sectional research. Okay, because you can look at disease, you can look at attitudes, you can look at behavior within the population at a specific time frame or moment. Another good thing about this type of design is that you can compare the measurement variables simultaneously. So again, you can look at other key factors rather than the exposure and the outcome that might require analysis, like what are the ages of the people that were in that population, their income level, health status, okay, how they differ across different groups, okay? And again, at the end of the day, if you're not looking for just a description or observation, you're looking for an association, then you can generate hypothesis or a hypothesis because you need to know the association between the outcome and the exposure. And these are very much important. Why? Because they give strength to the cross-sectional design. At the end of the day, you can come up with a strong association between two factors, or even you can say there is no association at all, so there is no time, no need to waste time. Type. Still, there are a bit of limitations that are inevitable. The first one is no causality. Okay, so you know that there's a relationship between cancer, lung cancer, and smoking. Okay, but did you know the cause? What was the triggering factor? You just know that a lot of patients, or 90% of the patients having lung cancers who are smokers, get to the third stage by that month, or get to that stage by a specific period of time, or they're faster in getting to the third stage than others. We know that as a fact, but what caused this? We never targeted this. We never had an intervention to examine, or we never got to a molecular level to examine. We did not divide them into randomized groups to look at what makes that difference or that change. Okay, so the data is collected at only one time point. It's impossible to determine the exposure causing the outcome. You just know that there's a relationship. Okay, so again, this is what they call a temporal paradox. Okay, because the time here is your main constraint, although it's your objective. You want to look at a specific period of time. And that takes us to the other limitation, which is a snapshot limitation. So the findings you're talking about and the results may not reflect the long-term trends or changes because it's not a longitudinal design. You cannot predict what happens next on the long term. Okay? So again, it's not reflecting the long-term trends or changes over time. For that, you need a longitudinal trial. Okay? Third, because your sample is a convenient sample, you're taking a sample that you already know from the population. You're picking up your sample on your own. Okay, so it's always accused of having a sampling bias and reliance on self-report. Because again, if we're talking about surveys, the survey is being filled out by the subject himself or herself, so he has the liberty to write what he wants, even if he doesn't believe in it. We're not sure of what's in his conscience. You're trying your best to use a validated and reliable questionnaire, but again, it's still subjective. You're based on subjective data. The other point, as a researcher, you have handpicked your sample, which provides a good bit of sampling bias because it's convenient. So again, for strength, it's relatively quick and easy to conduct because you don't require long periods of time. Data on all variables are collected once, so there is no follow-up needed. You can measure the prevalence of all factors under investigation with one design. You don't need to do different designs. And you can, again, study multiple outcomes and the multiple exposures at the same time. Again, all these characteristics help in assessment of burden of diseases. But as I said, we can also look for attitudes and behavior. And this helps in further or future planning and allocating health resources. When you're talking about descriptive analysis and generating hypotheses, again, the cross-sectional design serves a good platform. Why? You have the analytical side of the cross-sectional design and you have the observational side of the cross-sectional design. And as we said, it can be a platform for studies, other studies like the cohort studies. When it comes to weaknesses, again, we can say in other words, it's difficult to determine sequence. Which follows which? Does the outcome follow the exposure, or with time does the exposure come next? Again, you know that something happened and both are related together, but which one came first? For diseases with a short period of time, or like rare diseases or short outbreaks, it's not suitable for studying them. Why? Because again, you're taking a snapshot. So again, some factors might be missed or some related risk factors or related predictors might not be assessed properly. Again, the cross-sectional studies would measure the prevalence, but it would never measure the incidence. And again, the prevalence, you're looking at how much or how likely something to happen within that short period of time, not something happening incidentally with having a cause and relating them together. One of the things about cross-sectional designs is sometimes when you find association, yes, there is an association and it's a strong one, but it's not easy to interpret the association. So again, the association is present and it's clear, but again, because again, we're not talking about causality, you cannot rely on a specific foundation to tell you why is this association happening or what brought this association to that point of strength. Again, there might be susceptible bias, as we said, because of the convenient sampling, but another cause of the bias would be low response rates, for instance, in surveys. So again, sometimes when you have surveys being spread out, or you're taking data demographically using questionnaires, again, the low response rate and misclassifications might result in susceptible bias. Again, we said it tends to identify prevalent cases for long diseases or chronic condition, but not those on the short term or for short snapshots. So at the end, what I want to say is that cross-sectional designs is an important tool when it comes to observing a population to find prevalences and association between an outcome and an exposure. And having that being said, this does not in any way decrease the importance of cross-sectional design, because if it wasn't for cross-sectional designs, if we're talking about epidemiological studies or prevalences, how would have we known that the prevalence rates of diseases or the prevalence rates of improvement following specific medications? Couldn't have happened. At the same time, the associations between the exposures and the outcomes, it's an important factor that you can get out from cross-sectional designs. Yet, what we always tend to recommend is if you have a cross-sectional design showing you there's association between factors, go ahead and pursue for further recommendation to have another study with a different design to look at the causality. Why is there an effect of X on Y? Or why was Y affected because of the presence of X? That's so much important. And again, if you're looking for studying on different timelines, a cross-sectional design can be the standing platform, and you can go later on with a longitudinal study or a cohort study. Anyway, I'm happy that I summarized this. I hope I wasn't boring, and I hope it was beneficial, and I'm free for any questions.
Thank you very much, Dr. Tamer. It wasn't boring at all, and it was a very informative, direct to the point. And I'm, just looking at the question and the interaction of the audience, I can tell you that many people kind of benefiting from the information that you shared with us. So thank you very much for that.
My pleasure.
Like I think for me, I always say that as a researcher, you have to keep your mind active, asking research question and keep going on and sustain that. And sometimes, as you said, if you have a limitation of a time, of resources, you will find that it's a bit challenging to do interventional or, like trials, for example, clinical trials, or, like any sort of study that needs a lot of support from different perspectives. So cross-sectional, first, before cross-sectional, by the way, the last webinar, it was about cohort studies. And we also talked about how you need time to follow up and to find more as you go, through the time. Uh, you know, it's very important to say that you can manage the time if you have the luxury of time. But, if you don't have that, I think cross-sectional come as a very important methodology. But I think because many people, because we say that it is cost effective, it is quick and all of that, people question the weaknesses of it. And that's why I think the first question from the audience, they're asking about PhD students. If a PhD students adopted this kind of model to conduct research, which is, cross-sectional design, do you think it is strong enough for them to, like to get their PhD at the end of their research? Or
It depends,
what's your
from my point.
suggestion?
Well, that's a very good question. It depends on the discipline. Okay, they're
Mm,
studying. Again, some disciplines in humanities, for instance, yeah, it's their only way of grabbing their data. If they're looking at specific behaviors and attitudes in the society, for instance, most of them would get the benefit from using validated questionnaires, and that's the most important thing, the outcome tool you're using. Okay, so again, it depends on what are you looking for, because again, a research question, a very good research question, can now come up from the mind of a PhD student, and it can really enrich science later on. And this is the only approach it can be done, because again, you want to look at the again, the likelihood of quitting smoking in a society.
Mm,
Okay. So again, you cannot expose a group to smoking and then let them quit. You have to take an observational design. And one part of that design is looking at the prevalence of the people who already were smokers and quit and looking how that links later to your study. Okay, so you can have one part as a cross section and later on you can build up with another design. Or even if you'd like to keep it as a cross-sectional design within the clinical context of the medicine, a lot of studies are being coming out. Why? Because at the end you're looking at an association. So
mm,
again, if I'm looking at the relationship or the association between cognition and healthy diets in elderly,
mm,
okay, or the diet the diet intake for elderly or their physical activity levels. Okay, I'm not going to impose a specific physical activity level on them. Okay,
mm,
I'm just going to follow them in that short period of time or that snapshot of time. Okay,
mm,
and correlate and put the dots together and get an association. So
mm,
again, every PhD student would have a supervisor that can tackle the weaknesses and tweak them so they're points of strength. And yes, it's a viable design for PhD students. We have seen a lot of cases, but again, people underestimate cross-sectional studies. I don't like that.
mhm,
Why? Because without cross-sectional studies, you would never know the prevalences, you never know associations. But yani one thing from my point that I didn't say is that it requires a large sample size, a very huge sample size. If you
mm,
wanted to generalize your findings, the most important sample size calculation, when it comes to cross-sectional designs, it requires a big, substantial sample size. Of course, it differs
mm,
from one discipline to the other. But again, I
mm.
hope this answered the question.
Yes, it answers the question. Actually, it will lead to the second question. But before I go to that, especially if you want to look at the community, for example, we have our some of our students who go to the community, to different parts of the community, and ask a certain research question. Again, you cannot follow up with these people. You cannot control that. You cannot, like do
Of
everything
course.
that you do with the other design. So if you want to expose yourself to large population in a specific snapshot kind of model, I think cross-sectional would come to, like the best kind of model for that. But you,
Of
you
course.
mentioned that you can make it stronger. And this is the second question. Okay, if we're going ahead with the cross-sectional for whatever reason, then how you can make it strong? You already mentioned one point by large sample size. Any other factors that can make it stronger or more convenient or more convincing? Yeah.
Okay, so the thing is about the population, which is the most important thing that makes it, يعني, as a strength at the weak point, which is the sampling bias. Okay,
Mm,
so again, if you want to tackle it and make it stronger, you have to have a very good inclusion criteria. Okay,
mm,
so again, you're looking at a population, specific population, and you're targeting something or an exposure
mm,
to find an outcome or a relation with an outcome. So again, having a very good selection criteria for your inclusion is very much important. Why? Because you want to put out of the mind of the reviewers or whoever is doing the work, or even from yourself, that you're biased to a specific sample. Because again, when you have the sample in the population, they're easily picked. So you can take
mm,
the sample. But again, if I'm looking at junior ages, okay, so I'm putting again a very hard scale about that frame. Yes, I'm going to take the junior population. There are a lot of juniors in the community, but again, I need them to be non-smokers, physically active with a specific level. I need them to be match groups of boys and girls. I need them to be having healthy food without. So you can target specific inclusion criteria to make your sample reflective to what you want actually to measure. Okay. The other point is again, don't just go for the observational prevalence study. Go for an analytical because it's you already have the data. Okay,
mm,
at the end you just need to look at the odds ratio or have a statistical analysis that can be used to look at the correlation or the association. Okay, so
mm,
don't just keep it like, okay, I've seen this happen. Yes, you've seen it. And now what? You need to say there's a strong relationship between these two, and we need to further investigate it in one way or another. So again, having a solid outcome for an association or relationship is very much important.
mm. Yeah. Thank you for that. And there is a second question, and you kind of touched on it before about, is it okay to start cross-sectional and somebody else to come and continue adopting different design. I think you mentioned that. So he's asking about can we use the information that's being collected based on cross-sectional or the outcome of cross-sectional to continue a different type of research. And I think you, if you want to elaborate more, but I think you touched on that, yeah.
Well, yes, I said it's possible, but again, there's a thin line here that they shouldn't cross. Again, when you're talking about diseases, okay, there are many factors that might be confounding to the disease or many factors affecting the disease. So if you're talking about study looking at, for instance, COVID, okay, everybody was affected with the COVID, but again, there are studies talking about specific races, a dark color versus Hispanic, for instance, who has higher prevalences. Okay, so you cannot compare apples to oranges when it comes to deep specifics. Again, you can take data that are related again to your inclusion criteria. If we're in the Middle East and you want to take data related to the Middle East and continue from that point further, you can. But again, there shouldn't be a long time gap. There shouldn't be a long time gap. Why? Because again, time in itself, there are things that should change with time. Okay.
Mm,
Again, so if you're talking about the prevalence of a specific disease, and now there is a new medicine that is present, so a lot of that population are now looking for that. And let's give a live example of, and again, this is not an ad. So there has been this medication for losing weight, Mounjaro and Ozempic, right?
yeah.
Before there wasn't. There was different methods of losing weight. Am I
Mm,
correct? So if they were
mm,
looking at the prevalences of losing weight based on or taking medicine, okay, at specific point, at that specific point before, these two medicines were not present, right?
mm,
So if you want to build up on a study, you need to build up on a study that has the same variables that are present, or else you have to start all over. Why? Because you have a new factor, a new variable that entered in your pool.
yeah.
Okay.
Yeah, so continuation, it's very, if you want to continue, it's very important to make sure that the factors are the same, the microenvironment is the same when, like to have a kind of coherent outcomes. We have a question, somebody's questioning if there is a lot of limitation, and we talked about it in the cross-sectional, then is it methodological appropriate to integrate the root cause analysis frameworks to support causal interpretation and contextual understanding of the observed association. Also, you touched on that. Yeah, yes,
Okay, so
yeah.
this is a shortcut. Okay, so that was something like people wanted to outsmart researchers, so they would just augment their cross-sectional design, okay, using other statistical analysis that might find causality. Okay, but remember, the actual design of the cross-sectional studies was not intended to look at cause.
Mm,
Okay, so again, if you did this and you wanted to publish an article or a paper, the first question would say, if you wanted to look at the cause, why not do an interventional study?
mm,
Which makes sense. If you wanted to look at a cause from the start, then your design should have been different. Okay.
mm,
Again, this would provide, yes, causal interpretation, so for some of the variables, but not all of them. Because if you're talking about attitudes and behaviors, that statistical design might not fit. Okay, it might
mm,
fit something else. So again, it was one, let's say, intelligent method to try to find a cause between the variables, a causality between the variables. It can be used, but again, the first thing that would come to any reviewer's mind, okay, if you wanted to look at the cause, why not from the start go for an interventional study? And you have to justify yourself. It's either you had the intention to start with a cross-sectional design, but you found out something that is pushing you to look for a cause, and that's why you had to do this. But
mm.
this is not the case in all studies that are using this. Okay?
Mm, yeah, so you have to be very careful what you're presenting out of that outcome. There is a question. I think maybe somebody didn't really get the point when you mention one of the strengths or how you can make the cross-sectional studies strong by having a larger sample size. So he's saying, there is a specific number? Of course, there is no specific
Of
number,
course.
but if you can explain this more to them.
Okay, okay. When it comes to research, again, you want to generalize your findings at the end. And generalizability means, okay, so you want to be on a solid basis of saying, okay, I said X is the reason for Y. Okay, so that goes for all. Okay, how can you generalize? First, you have to be away from any bias, and that comes with other designs like the randomized control trials or the and the controlled trials. So you're randomizing and you're controlling the environment where you're having the experiment. But if you don't have that in cross-sectional design, this would be made up by looking at a larger sample. Why? Because when you're looking at a larger sample at the end of the day, you're decreasing the minimal differences. So again, I don't remember the name. There's one theory in statistics. The larger the sample you have, the less the variations in standard deviations. The minimal significant difference would be better. So again, the larger sample you're having, the variations gets less if you're having a homogeneous population. When I
Mm,
say a homogeneous population, again, I'm talking about inclusion criteria. You have a specific criteria you're following in the population you're taking from the environment. So
mm,
I'll give you another example. If we're saying, okay, I have 5 students, okay, I give them an exam and 3 of them fail.
mm,
So is the problem in my exam or in the students? You can
mm,
never know, or you can never for sure say, okay, his exam is difficult or they didn't study well. If you hear their
mm,
side of the story, they say, no, we studied well, the exam was difficult. If I said the exam was easy, but they didn't study, who's correct? But if I
mm,
have a batch of 200 students, and then
mm,
at the end of the day, you look at the distribution of the grades, the 200 as a large population was reflecting different variability in that population and decreasing the variability when it comes to standard deviations. The errors would be less. So
mm,
again, at the end of the day, when I'm looking at that graph, hey, I have 70% of my student passed. So I
mm,
can generalize or I can extend my grounds. So
mm.
this is the concept of having a large population. A large population is required, or let's say a proper number of participants is required. And how do we do that? Again, there are sample size calculations for
Mm.
both qualitative research and quantitative research.
Yeah.
A lot of tools are used, like the G Power, for instance. Okay,
Mm,
it's a software where you get to put, okay, how many groups you need, the alpha level, the power of your statistics, the mean difference if you're relying on other clinical studies, the mean difference between the groups that were present, and then it would give you an estimate of the least number that is required for research. The same goes for cross-sectional designs. You need
mm.
to have a proper sample size or not less than a specific sample size so that you can generalize your findings.
Yeah. So just a different point related to when it comes to cross-sectional, for example, and you're doing a survey and you're doing the survey face to face in the community or whatever in different settings, and you're doing a different study online. So do you think which one is more trusted or there is no difference? Or what do you think, your personal view on this, the difference between the two, between
Okay.
online surveying and face-to-face
Well,
surveying?
again, it depends on the way you're looking at the compliance of the participant. Okay.
Mm,
Because you can have the survey online, yet you're available for any questions with the
mm,
subject, as if you were instead of being face to face, or you can just send it on a Google form and they would send you the reply. And this is what we said. There might be a low response rate or a false response rate. Okay.
mm,
Usually, when it came to the in the past, they had to do the surveys face to face. But now
mm.
we're living in a tech savvy environment. Everybody has their phones, they have the internet, and they have to utilize this. So
Yes.
again, there are the problem with surveys again, they have a specific means of adjustment for errors. Okay.
Mm,
The face-to-face, of course, had less adjustments. Why? Because you're face to face. If he has a question that he didn't understand, he would just talk with me and ask. Or I'm just giving the question, I'm the one that is giving the question and interpreting it and taking the answer. But when it
mm,
comes to online now, again, one of the limitations is that okay, sometimes people don't have time, so they just tick whatever, or they don't.
mhm,
So, but again, there are specific softwares that would eliminate these surveys.
mm,
And as in clinical trials, we have something called the intent to treat, to substitute. There's another method for intent to solve, also for cross-sectional surveys. Sorry, I don't remember the actual name of it, but again, it's the same concept. So if you
mm,
have the main data available, you can have the intent to treat as the mean of what was supposed to be for that lost subject. We have the same for cross-section designs as well.
Yeah, sure. And sorry, we keep asking you a lot of questions. This is the
Oh.
last one, and it is a very general question, I would say. So if you have any specific remarks that you want to say. So somebody asking, what are the resources to gather information for research that would avoid selection bias as much as possible? Very general question, but if you have any thoughts, yeah, about this.
Again, selection bias in cross-sectional designs is, again, it depends on the conscience of the researcher. Okay, again, we're all fixed to an ethical conduct. So we know the ethics of research, we know what we should do, we know right from wrong, again. But again, the problem is sometimes you're biased to your idea, especially when you're young research. Some people have the wrong notion that, okay, since I'm doing research, I have to prove something.
Mm,
Okay, if you've proven that something does not have an effect, you still enrich knowledge because you've saved time from other people. They would
mm,
start from where you ended. They would say, okay, Dr. Bashir said this has no impact, so we agree with her. Khalas, we can start from another dimension. But
mm,
again, don't be biased for yourself and your idea. That's one thing. That's why young researchers always start with null hypothesis or hypothesis. There will be
mm,
no significant effects of X and Y. Why do we start with that? Because we want to say we're not biased. If we find an outcome, hooray, that would be great. If we don't find an outcome, we have still enriched knowledge.
mm,
The designs that help exclude bias when it comes to sampling are randomized control trials. Basically,
mm,
all control trials, when you have randomization, because you can use sequential randomization, you can use block randomization, you can match paired groups still with randomization, again, within a controlled environment. This is why they come on the top of the hill of research, because at
mm,
that time you can blind yourself as a researcher and have the subject blinded from the intervention. So you can have the randomization, and yet both parties are blinded of what is being happening. Or as an intervention, I cannot have a hand in it. I can just ask a colleague, just do this without
mm.
even knowing why. So he's still blind to the outcome of the research. So at the end of the day, randomization and blinding are the best methods to avoid bias.
Yes. Thank you very much, Dr. Tamer, for a very enjoyable discussion. We really appreciate your 1 hour. I know that is very difficult time now. Thank you very much for being available for us. And definitely in the future, we will be in touch for more discussion regarding different topics in research. Thank you very much and have a great evening.
My pleasure, Prof. Bashir. I really
Thank you.
enjoyed the evening and I hope it was beneficial. See you
Thank
again.
you. Thank you very much, Sia. So we will keep, doing our webinars, and we always talk about the participants, and it's very important to have the right participant at the right time. Like you have to be sure about the characteristics and all of that. But yet we have a lot of challenges about that, about recruiting participants for research, and there is several factors kind of stand as a barrier for recruiting the right number or the right group of participants. That's why our next webinar will be on the 4th of June about bringing participants on board. What are the best practices for that, and what is like how you can develop a successful protocol for that. That will be by Dr. Hamza. After that, we'll finish this set of webinars, the second phase, with a very important local issue, especially for the researchers in the UAE when they want to conduct any sort of research, especially interventional. They need a very strong kind of approval from the ethics authorities, and we do have somebody knowledgeable from there, Dr. Mahda from DHA. She will be talking to us about the regulations, the guidelines in DHA. That will be on Thursday, 25th of June, and that will be the last group on that. So as I said, we will have Dr. Hamza next time for the 11th webinar. It gives me a great pleasure to kind of share with you that our Master of Science in Diabetes Management is right now the registration or the admission is open for it. So if you are interested in diabetes, and I'm a bit sure that we have a very decent number of attendees who are interested in diabetes, if you want to advance your career, if you want to make a difference difference in the life of patients with diabetes through knowledge, through research, through clinical research, and clinical understanding of the diabetes management challenges, please just scan the QR code for the program details for registration details. Also, are very happy to announce that we have a new series of webinars. It's called Meet the Professor. It is focusing mainly in endocrine. So if you are interested in endocrinology, please make sure to attend this new set of webinars, and it will start on Thursday on the 18th of June. If you would like to get the CME points, please make sure that you fill in all the forms, evaluation forms that you will receive through your emails. Because once you're done with that, then you will get the CME's points. The webinar, as I mentioned before, for the people who were asking in the chat box about where it is available, it's available on demand from the EDES Institute website. Here is the link, as well as, like you can know more about the upcoming webinars from the same website. Thank you very much for being with us today, and just stay tuned for our next group of webinars. Wishing all of you great weekend and happy Eid for the people who are celebrating Eid, and we'll see you in our next webinar on the 4th of June. See you. Bye-bye.